Dr. Ginde is a professor in the Department of Emergency Medicine and Anesthesiology here at the University of Colorado Anschutz. And Dr. Ginde has really played a leading role in COVID treatment research on a not just a local level here, but on a national level. And he's served on steering committees and task force and as a protocol chair for national protocols. And he's been leading an effort here in Colorado to look at the effectiveness of COVID monoclonal antibody treatments, and that's what he's going to speak about today. So Adit, welcome, and the podium is yours.
Great, thanks for that introduction, Tom, and to the CCTSI for giving some time for our MAB Colorado project. It was a great segue to talk about therapeutics, because this is sort of a transition from vaccine prevention to a little bit of therapeutic prevention. We're going to be talking about implementation, effectiveness, and equity issues related to monoclonal antibody therapy, real-world setting. Brief disclosures. So this project is funded through a generous supplement from Anschutz to the CCTSI award, starting in mid-March, with no conflicts of interest to report. I do want to highlight that this is a huge team that's involved in this project. These are just the team leads who putting a tremendous amount of effort. So Dr. Bethany Kwan is on today's call, is leading the dissemination implementation lead, and has put a tremendous amount of expertise and effort in this project. Dr. Winia with the clinical leadership, informatics leadership from Dr. Tel Bennett, and biostatistics from Dr. Carlson. As you'll see, this is a lot of ground to cover in this project, and we've kind of leveraged the full weight of the CCTSI and the core leadership to help with this project.
Dr. Could you put your slides in presentation mode, please?
Yeah, I'm trying. Let me try and unshare and reshare. Thanks, Wendy. Let me see. Other putting it on the wrong screen, but let me see. You seeing presentation mode now?
That looks great. Thank you. Perfect.
Okay, great. Thank you for flagging that. Okay. We've looked at this before. Won't belabor the latest surge. Just wanted to mention that our focus is really on hospitalizations, as well as getting people better faster. But just with the increase in cases, we're also seeing a mirrored increase in hospitalizations. And Colorado is really no different here in terms of an increase in hospitalizations. We haven't seen a spike in deaths yet, but definitely of concern here, and leading to concerning figures such as this, which is county level community transmission. We don't want to see this map with any red, and we're almost all red. Colorado is actually, as Dr. Campbell mentioned, doing a little bit better, only because we're seeing a little bit of yellow and orange, but still a lot of work to be done and some concerning weeks and months ahead. So when we think about this spectrum of illness, from a healthy patient all the way to an ICU patient, and then recovery, our focus here really is in the early symptomatic infection zone, and trying to prevent people from progressing to hospitalization, ICU admission, and death, as well as helping to speed the timing and quality of recovery, which is a big issue for patients with antiviral agents. So we talked a little bit in previous sessions about monoclonal antibodies. This is not anything new in terms of a technology. Really starting in the 1970s is when research on monoclonal antibodies for various conditions started. Cancer therapeutics, infectious disease therapeutics. There's 4 listed FDA-approved monoclonal antibodies for other conditions that have come out. And so when the therapeutic strategy at the federal government level was initiated in spring of 2020, monoclonal antibodies really at the top of the list for enthusiasm in terms of potential for effectiveness. So this has been a major focus since then of research in the prophylactic outpatient and inpatient settings. So these are synthetic neutralizing IgG molecules to treat the SARS-CoV-2 virus. They're isolated originally from recovered patients. And since they were manufactured earlier as from the wild type virus. One exception is the Vir molecule was actually isolated from a original SARS 1 patient, so the original SARS virus, which has unique features in terms of prevention of viral escape. But these essentially bind to the spike protein, which we've talked about, and block interaction with the ACE2 receptor in host cells, prevent cell entry, prevent viral replication, and thereby neutralize the virus. These can be single agents or combined into 2 antibody cocktails informally. And having complementary non-overlapping binding sites can help treatment efficacy and also is potentially important to prevent escape mutations. So just walking us through the brief story. So our story starting about 9 months ago last fall, when we started to see some results of monoclonal antibodies in the outpatient setting. So this is the single Lilly monoclonal bamlanivimab in outpatients, only a few hundred patients, published in the New England Journal, showing in a secondary outcome, not the primary endpoint of day 11 viral load, modest reduction in viral load, and then really anchoring on prevention of hospitalization, a reduction in hospitalizations, but dealing with pretty low numbers, 9 hospitalizations in the placebo group, 5 hospitalizations in the intervention group, although double the size. But we were desperate at that point for effective therapeutics. And that led to an early November emergency use authorization by the FDA to use bamlanivimab for high-risk outpatients. Criteria were a little stricter than they were today, but are listed here: high-risk conditions and older adults. Regeneron followed soon thereafter by press release and then followed by a New England Journal publication, 800 patients, similar type of findings, all comers, 57% reduction in medical visits for COVID-19 and a particular effect in high-risk patients, leading to its monoclonal antibody emergency use authorization. And these started to be distributed in late November, early December, as really the only thing in the arsenal for outpatients and high-risk outpatients that were at risk for disease progression. But there were some challenges. At that time, there were limited availability of monoclonal antibodies. If every eligible patient received monoclonal antibodies, we would run out of drug in about 48 hours. And so the state, CDPHE, along with Matt Winio's on our MAB Colorado team and others at CU Anschutz, helped to develop a random allocation system for administering treatment. However, there was quite limited utilization of treatment. At that time, really less than 1% of eligible patients were accessing treatment, so random allocation never meaningfully was turned on. There's equity issues. Most of the patients receiving monoclonal antibodies are non-Hispanic white patients with really good access to care, so not really reflective of the burden of disease of the pandemic. And at that time, there was quite a bit of uncertainty about the benefits of treatment. We were dealing with phase 2, few hundred patient trials, still not really enough data to feel completely comfortable about risk. So we're in an interesting time as far as therapeutics, and that was sort of the origin of our project, which was really building on what we knew and what we didn't know, and some of the challenges mentioned, to do a hybrid implementation effectiveness design. So there's still some work to do on effectiveness at that time. Looking at barriers and facilitators to use at that time, very low utilization, and we knew that. And we knew that was going to be a challenge. And then developing strategies for statewide implementation with a focus on equity of access. And then all the while continuing to monitor real world effectiveness and safety amongst the eligible population. And especially as variants were to change, as others preceding speakers mentioned, there's concerns about resistance and viral escape maintenance. And we had some lofty goals and still do in this project. We're only about 5 months in, seems like many years in. But the focus of federal efforts was largely on identifying effective therapeutics. But as a clinical trialist, that was compelling to me, as I've spent a lot of time with Dr. Kwan and her team on the implementation science side. That is really only the beginning. So once we actually find an effective therapeutic, we just have to deliver it to people. Otherwise, the billions of dollars that are spent on therapeutic development are essentially for naught. And that's been a real challenge in the implementation of monoclonal antibodies. We want to help provide data and information to help policymakers, administrators, clinicians, patients manage the issues that we've mentioned. There's a number of issues around uncertainty, risk, urgency of the treatments in the pandemic, as well as the resource limitations and equity. And then rapidly generate real world evidence that could be used in this pandemic, and then create a model for future pandemics and public health emergencies. So some pretty lofty goals there. We are using a mixed method approach in AIM-1, using diffusion of innovation theory to look at barriers and facilitators. We'll have some preliminary results to show you about what that looks like. And then AIMS 2 and 3 focus on a pragmatic implementation effectiveness hybrid design. So implementing strategies to improve access and uptake, and evaluating those strategies, and simultaneously evaluating real world effectiveness. So you'll see a bunch of tools developed by the large team on the MAB Colorado project as we start to go through here. Here are the current eligibility criteria. So you'll see essentially any comorbid condition or any high-risk population, including racial and ethnic minorities, or older adults, makes you eligible as long as you're not been hospitalized and not on new supplemental oxygen. Here's the age requirement for the prior session. So basically about 3/4 of symptomatic outpatients are eligible for treatment. We've started to map out access. So it looks on the surface, here are infusion centers. It turns out that administering intravenous outpatient therapy that's time sensitive in a pandemic is not particularly straightforward. There's more than 30 designated infusion sites around the state. This map looks like we have reasonable coverage, but if you dig in, some of these centers may offer treatment slots 1 or 2 times per day. It's hard to access treatment. We've learned a lot about the challenges of implementation. Here was our early map. So this is around referrals for treatments, with darker blue being better, higher density. Gray means either there's no referrals or no treatment centers available. So clearly had a lot of work to do early on in the project, and still do. Now more data keeps coming out. Here's a preprint from a couple months ago from Regeneron, now showing the final phase 3 data. This is under peer review and is expected to come out in the next few weeks to month in the peer review literature, but essentially 4,000 patients seeing a remarkable reduction in hospitalization, over 70%, as well as a 4-day faster symptom recovery, which is quite a patient-centered outcome with low risk for adverse reactions. The Lilly combination agent had similar results, 80% reduction in hospitalizations, which is actually a really remarkable finding for symptomatic outpatients. These were all published in the last couple months. However, we have to keep up with the changing times. So as Dr. Campbell showed in the prior presentation, there's resistance developing to bamlanivimab, as well as a combination agent. And so the distribution of this combination agent is paused at the federal level. And that's sort of simultaneous with the phase 3 data. So things change really quickly, and our team is having to keep up with this. Here's some more changes. Subcutaneous dosing of the Regeneron combination product is now available if IV treatment is not available immediately. And then, as was mentioned by Dr. Marovich, post-exposure prophylaxis, especially for high-risk patients, is authorized as well for the combination project. So a lot going on, and these, you'll look at these dates fly by. This is only really in the last couple months, and it's been the pace of change. Here's the NIH treatment guidelines. I won't belabor, but a class A recommendation for the Regeneron product and the GSK Vir product. We haven't mentioned that that's only in press release form, but is authorized for use. Primarily, most health systems are using the Regeneron product. And there is a recommendation against use of the Lilly product because of resistance right now, but it's still sort of on the shelf if variants were to change for later. Here's how we summarize. Our dissemination implementation team summarizes some of the information. We have a graphic novel that's been developed by the team to help disseminate, but essentially highlighting the prevention of hospitalizations and the reduction of symptom duration, including effectiveness against the Delta variant. So here are some key findings from the AIM-1 barriers and facilitators work. So this was a provider survey, has already met the goal enrollment of at least 350 providers across multiple specialties across the state. There's also in progress community surveys to understand the patient and community perspectives, including patients that have been tested, vaccinated, treated, and those who have not. We'll focus on the provider survey. So the majority have seen a COVID patient and even at least one eligible for monoclonal COVID patient in the last month, but not very many. There's reasonable interest in prescribing monoclonal treatment, but we'll see some of the barriers. But it's not common that providers are seeing many patients in a month. So some of the process issues about ordering treatment are really challenging. Here's some of the knowledge questions. So some knowledge, but not a large amount. You know, very few providers are familiar with the product, familiar with eligibility in a major way. There's kind of heard about it. We're not exactly sure all the data. And then it gets even worse about how to order it, or sorry, the strength of evidence, which is, you know, most people don't know. And these are healthcare providers. A number of barriers that have been mentioned related to the ordering process, uncertainty about cost. The drug is provided for free through a federal purchase, but sometimes the infusion charges are a little bit tricky to navigate. And just a very complex system to get patients an IV treatment. The community survey results. So these are patients and community members. You know, this is comparing essentially knowledge about COVID testing and COVID vaccines to monoclonal antibodies and other treatments. You see, most people feel pretty comfortable with testing and vaccination, and relatively uncomfortable or not knowing much about monoclonal antibodies and other treatments. Not surprising because we, you know, saw similar results from patients as well. And then specific questions about specific monoclonal antibodies, just really not a lot of knowledge out there in the community. So sort of a patient-driven approach to asking for treatment. There's a fair amount of work to do here as well. There's a reasonable willingness to accept the treatment, even though it's an intravenous treatment. It's a one-time intravenous treatment if the doctor recommends it. So that is a modest barrier. There's some hesitance against an IV treatment, but it's not sort of a primary barrier. That's kind of what we've learned from AIM-1. So that coincides with some of the implementation strategies which are happening in parallel. So there's a number of groups giving feedback to the team, stakeholder advisory panel, including a multidisciplinary group of community and healthcare organization members, the community engagement studios to get focused feedback, really a tremendous amount of work and effort going into trying to figure out the strategies for co-design of implementation strategies. I'll just fly through a few of the products. So there's a pretty robust website, mapcolorado.org, that has patient-facing information, healthcare provider, and then linking patients to monoclonal antibody research that's been developed by the team. Very active Twitter feed and social media posting with a large number of views and impressions. And this is sort of really trying to get the word out to the population and providers. Here's some more images from the graphic novel, which is one of my favorite MAB superheroes. There's a bunch of messaging and posters and other things that are going out. Here's a poster from a flyer for Mesa County So that's targeted, try to make it health literacy appropriate and tailored to the individual community. Mesa County is having a particular issue on the western slope with low vaccination rates. So that we were asked by CDPHE to spend some time focusing on that particular area. And then healthcare provider facing messages. We saw loud and clear the barriers to understanding and knowledge around the treatment itself and ordering. So trying to simplify messages, doing outreach through Project Echo and other venues. And then just trying to build capacity. So the capacity is pretty low. We now have plenty of drug available that's been manufactured, but the capacity for infusion has been a barrier now to access as we've increased messaging and increasing demand for treatment. So the UC Health Virtual Health Center, led by Dr. Chris Davis, has been a tremendous partner in helping to improve access. Denver Health, Dr. Lindsay Fish is the lead there, has been administering for Denver Health patients and Denver City or Denver County and Denver Public Health monoclonal antibodies in their urgent care center, working with local public health agencies, particularly Tri-County Health Department, and then exploring partnerships for a patient-facing call center, as well as expanding access in urgent care centers, as well as home infusions. Continuing to track use of the monoclonals, here's a slightly different map. We're starting to see some darker colors and definitely some increased use. So this will be continued to track as the implementation activities occur. And then finally, and I'll stop after a couple slides, this is the AIM-3, the real world effectiveness study. So we've leveraged this type of information for vaccine studies as well as therapeutic studies. And it's tremendously important. The ascertainment of knowledge about efficacy and effectiveness does not stop with the clinical trial. And I think we've learned and heard loud and clear that the changing of the pandemic, waning vaccine immunity potentially in certain populations, if not the general population, variants, et cetera, we have to continuously monitor what's working and what's not working. So that's the focus here. A number of data sources are feeding into this, led by Health Data Compass, a data feed that's forthcoming from Denver Health and Denver Public Health, linkage activities with CDPHE and Colorado All Payer Claims Database, dividing essentially patients into symptomatic COVID-19 outpatients who did and did not receive monoclonal antibodies, and following them through the EHR for hospitalization and related outcomes and mortality, and then an in-depth survey that we contact patients at 2 weeks, 4 weeks, and 3 months around symptoms. There's still a lot of questions about symptom recovery, especially over a longer period of time, as well as more in-depth information about their health conditions, their hospitalizations, and other therapies that they've received. Here's a very simple version of the informatics structure that is led by Dr. Tal Bennett about the data processes. This is a tremendously complicated data system that is requiring substantive expertise from the informatics team and the biostats team from an analytics standpoint. But I think it's really going to serve as a model for this sort of real world effectiveness work. Now, this is just one result slide. This is just the demographics of those who were and were not treated with monoclonal antibodies. That all of these are symptomatic COVID patients who were eligible for treatment. As expected, those who were treated were older and more likely to have comorbid conditions. That's implicit in the criteria, and those higher risk patients or the providers may be more in tune with trying to get them treated. What's of concern and definitely a focus is a lower uptake amongst racial and ethnic minority groups here. Hispanic and non-Hispanic Black individuals are represented and have a lower incidence of monoclonal antibody use relative to non-Hispanic whites. So I think we're at time. This is just part of the team. Just wanted to emphasize a huge number of people here that are working hard on this project across the cores of the project, and a number of partners, including NCATS and a collaborative agreement with Dr. Cure as our program officer, a number of contractors and vendors. We can't do it all within our local team, so strategic partnerships with a number of folks as listed here. So I'll stop there and happy to take questions if we have time. Looks like the chat has been active, so. So let me see, Dr. Kwan, thank you for being active. I think, so there's a question about just the window of treatment. I just want to emphasize, asymptomatic individuals who have been exposed or early diagnosis can receive monoclonal antibody treatment. The capacity to give treatment is relatively limited right now, and we're trying to do what we can within the construct of the project to improve access and capacity. But the focus has been a little bit more on symptomatic individuals because they're one step closer to hospitalization and related outcomes that are of concern to us. So we focus more of our efforts on those patients, but definitely have the ability to think about asymptomatic individuals or post-exposure prophylaxis, particularly in the context of home infusions. We have a number of home infusion agencies that are piloting monoclonal antibody treatment. If they're already in the home and there's other people in the home that have been exposed, especially high-risk patients, it's a great time to just administer several treatments within that household for prevention of disease progression and prevention of infection. Looking at other comments. Dr. Kwan is putting some of our social media feeds if you want some more information as well. Question about subcutaneous delivery. So I think it was an important step to have an option that was not intravenous infusion. So the EUA specifically says this is for when intravenous infusion is not possible. So clearly there's a preference for IV treatment, but there are many settings, and we've been exploring, particularly in long-term care settings, nursing homes, et cetera, that subcutaneous delivery of the medication, either for prophylaxis or for early treatment, is a potential way to increase access in those populations where wide-scale IV treatment may not be possible. And then there's the potential for clinics and providers in the home that may not be certified for intravenous infusion may be able to deliver treatment subcutaneously. The pharmacokinetics are not quite as good, but there's still reasonable data for effect.
Adit, you may have mentioned this, but is there a delay to get vaccinated after you've gotten monoclonal antibody? There was early on, and I don't know about still.
Yeah, great question, Dr. Janoff. So the CDC recommendation still says there is a suggestion that you should wait 90 days after monoclonal antibody treatment. It's not really based on data. It's based on a couple of things. One, it's very rare to get a second infection, within 3 months of a primary infection. And the monoclonal antibody treatment, actually, the half-life is at least several weeks, depending on the product. So there's some durability of protection. There's actually clinical trials that we've just launched looking at timing of vaccination post-infection with or without monoclonal antibody treatment. So those results will be out in several months or so.
But that's the recommendation still, you don't get vaccinated for 3 months after monoclonal?
Yeah, it's not a hard requirement. So, an immunocompromised patient, I would recommend personally vaccination within 6 months.
Okay.
But, it's a sort of a little bit of a data-free zone. So
sure, good.
Some room for clinical judgment.
That's a great program. Thank you.
Thank you. Right, Adit, thank you very much. I would also add that people who have been vaccinated and have breakthrough infections if they have risk factors, they should definitely consider monoclonal antibodies.
Yeah, absolutely. And it's been a substantive proportion of the patients that are now getting infused with monoclonal antibodies, particularly in the immunocompromised group, which, definitely are at risk for hospitalization and other severe outcomes. There's a
Great,
question
well,
about PK pharmacokinetic differences between sub-Q and IV. There are some, I didn't present it here, but some good data for this. And IV kinetics and peak levels are definitely better, but subcutaneous does get adequate levels for viral neutralization. Good question.
Great. Well, Adit, again, thank you very much for that outstanding talk. It was great to really see what's going on here in Colorado with the monoclonal antibody programs. I expect that with the surge that we're getting at the start of the surge with Delta, these programs are going to become all the more important.